Okay. So for this lecture, I wanted to talk about just some medicines that we use to treat type 2 diabetes and some of the decision making that goes with like what is the best medicine for the patient. Next one. We'll talk about the medication options, some of the mechanisms of action, risks and benefits, and then which ones offer cardiovascular and renal benefits. Go ahead. This is just some kind of overview stuff. So metformin is the preferred initial agent most of the time, and we'll talk about like some other options later on, because now if you have heart disease or stroke or any type of cardiovascular disease, then sometimes you can start with a GLP-1 or SGLT2. But in most people, metformin is the preferred initial agent. And whenever you start it, it doesn't mean that if you like end up starting them on insulin that you have to stop it. It can be continued as long as it's tolerated and doesn't have contraindications, like their kidney function is still good, that kind of stuff. We always want to keep in mind who we want to start on insulin earlier. So if they're having weight loss, symptoms of hyperglycemia, their A1C is really high, so 10 or higher, or blood sugars are over 300s. And we always want to take a patient-centered approach. So do they have heart disease, kidney function problems? Think about like hypoglycemia risk, age, their impact on weight. So if they're trying to lose weight or not, cost, like insurance coverage type of stuff, risk for side effects, and patient preferences. So some people don't want injections, for example. Next. So just some more overview stuff. So if they have established heart disease or they're at high risk for heart disease or heart failure, like they have a big family history of heart problems, then you want to consider an SGLT2 inhibitor or GLP-1 agonist because these have cardiovascular benefit. If they have established kidney disease, consider an SGLT2 inhibitor. GLP-1 agonist is preferred to insulin when possible, just because of all its benefits, which we'll talk about. And then you always want to intensify the treatment for people that are not meeting goals. You don't want to delay treatment. Just like you don't want to be like, oh, I'll give you 6 months to get your sugars down with diet, because you don't want to leave sugars untreated that long. And then the medication regimen and how they're taking their medicines should always be reevaluated at their appointment. So if someone tells you, for example, they're on Humalog 3 times a day, and you want to ask them like, okay, so how many times a day are you missing a dose? Or how many times a week are you missing doses? That kind of thing. So that way you actually know, are they taking it or are they forgetting a lot of doses? And then be careful with over basalization. So too much like Lantus or Toujeo or Tresiba, for example. So some signals of that are a basal dose more than 0.5 units per kilogram per day. They're having hypoglycemia, especially in the middle of the night, or fasting hypoglycemia. And then variability in glucose levels, like their sugars are really low in the morning and then really high later in the day. Next one. We'll talk about, these are all non-insulin medications that we're going to discuss today. Bigonide, so metformin, that's it. So the way that it works is it increases insulin-mediated glucose uptake in peripheral tissues, decreases hepatic glucose production and intestinal absorption of glucose. So basically it makes your body more sensitive to insulin. And then I did put, I don't know if you guys are going to get these slides, but I put like in the chart, like do their risk of hypoglycemia and stuff. So, and their weight changes and all of that. So metformin is kind of weight neutral, but some people do lose weight on it. It doesn't cause hypoglycemia. And the things we want to think about are kidney function and liver stuff. Next one. So a lot of benefits. It's cheap. It's just a pill. If someone doesn't tolerate the regular one, you can switch it to the extended release version. It's safe for use in pregnancy. Like I said, some weight loss, no lows. Contraindications are GFR less than 30, acute or chronic metabolic acidosis, and then be careful with hepatic impairment. You might have to adjust the dose or stop it if it's severe. Next. So yeah, GFR less than 30, you don't start it. But if they are already on metformin and say they're on 1,000 twice a day, which is usually the max dose, if their GFR drops less than 45, then reduce it to 500 BID. And then if it does drop more than to less than 30, then you can stop it. But you don't want to start it when their GFR is less than 45, but you can continue it if they're already on it, but at a lower dose. Next one. This is just the dosing for your information. So you just start with 500 twice a day, and then you can increase to 1,000 twice a day. We usually do after a week, but some people just tolerate just going to 1,000 twice a day, but I usually like to increase slower. Next. Now we'll switch to the SGLT2 inhibitors. So these are the Flozins. There's a new one called Brinzavi that's coming out. It's not on here, but it's the same. It's an SGLT2 inhibitor. So the way that these work is they basically help you pee out extra sugars. Next. So they have a lot of benefits. So they don't drop your sugars too low unless you're also on insulin or sulfonylurea. They help with heart failure and decrease risk of heart disease. And they reduce progression of diabetic kidney disease. Contraindications. So this is not an absolute contraindication with the prior episodes of DKA, but with SGLT2 inhibitors, if you get dehydrated or anybody with diabetes gets dehydrated, that can increase risk of DKA. And the one in SGLT2 inhibitors is specifically called euglycemic DKA, which means that the sugars are not as high as you would see typical DKA, but they still have a high anion gap. They still need an insulin drip, that kind of thing. But if they had one in the past and they were only on this, but now they are on insulin, then you can probably start it because now they're on insulin in addition to it, but it's just something to be aware if they've like had multiple or something like that. And I always tell people to let me know if they're going for a planned surgery or if they're sick, like they have the flu and they have like diarrhea and stuff like that will predispose them to dehydration, because then we'll want to hold it for a couple of days before, and then we can restart it after they're feeling better or after their surgery. You don't want to start it in people with recurrent UTIs or vaginal yeast infections. So with the SGLT2 inhibitors, if you start it and they get 1 or 2 yeast or urinary infections, you can just treat it. Just treat it with diflucan or antibiotic, whichever one. But if they get 3 or more, then we talk about reducing the dose or stopping the medicine. Foot ulcerations, when they were doing the original studies, they were worried about that in Invokana, which is canagliflozin. I don't know that that is still a worry there, and the risk of uncontrolled sugars on vascular disease is worse than being on an SGLT2 inhibitor. But I think most of us just don't use Invokana if someone had previous bad peripheral vascular disease, but we'll use the rest of them. And then the GFR cutoffs for empagliflozin and canagliflozin are less than 30, and dapagliflozin or tugliflozin less than 45. But now there's a different indication for some of the SGLT2 inhibitors to use it for heart failure, and in some of those you can go to a lower GFR to about 20. Next one. This is just the dosing, so I just wrote it out for you guys, but you guys can look at it later. Next. GLP-1s. So the way that GLP-1 receptors work is they tell the pancreas to make insulin only when your sugars are high. So that's called a glucose-dependent fashion. So that means that you can give it to people without diabetes to help them lose weight, and it won't drop their sugars too low. And then it slows down the gut and acts on appetite centers in the brain. So that's why people feel fuller faster and they don't feel as hungry. And that's how you can lose weight on these kinds of medicines. Next. So lots of benefits. They're really strong medicines in terms of lowering A1C. You lose weight on these, and the weight loss is very variable. I've had some people lose like 5 pounds. I've had some lose like 80 pounds. It's very like patient dependent. The cardiovascular benefit are with Trulicity, which is dulaglutide, liraglutide, and semaglutide. but probably it's all of them really. And then some of them, like Trulicity, are approved for like if you have cardiovascular disease. And then the reduced nephropathy outcomes with a couple of them, they don't cause low blood sugars unless you're on insulin and sulfonylureas. They're safe with kidney disease. The contraindications with these, so diabetes itself increases risk of pancreatitis. These medicines carry a small increased risk as well. So we tell people what it feels like and go to the ER if it happens. If the pancreatitis was from like it wasn't like idiopathic, you know, it was like gallstones or something, and then they had a cholecystectomy, then you can still use this because now you had a cause, it's resolved, you can use these medicines. They're contraindicated with history of medullary thyroid cancer or MEN2. And the reason for that is when they were doing the studies in rats, they saw a possible increased risk of these, but the data hasn't really shown this in people. But just to be safe, you'll see a warning on the boxes that say, don't take this if you or your family have medullary thyroid cancer. And then don't give it to someone who has gastroparesis because their gut is already slowed down. And then one of the ways this works is by slowing it down. So it'll make their nausea, vomiting worse. Next. These are just the doses. So Ozempic, it comes with its own pen needles. You start it at 0.25 once a week for 4 weeks, and you increase every 4 weeks to a max of 2 milligrams weekly. Next. Rybelsus is oral semaglutide. It's a daily pill. They want to take it about 30 minutes before, like in the morning. And you start with 3 milligrams daily for 30 days, then you go to 7 for 30 days, then the max is 14 on that one for now. Next. Trulicity, it comes in an auto injector. This is what it looks like, where you have to take the little gray part out of the bottom and then like unlock it pretty much, and then you hold it against your belly and inject. It also has 4 doses and you can increase every 4 weeks. Next. Victoza is a daily GLP. You can increase this one every week, just this 1 week. And then this one, you have to send pen needles with it because it doesn't come with its own pen needles. And they're probably going to come out with a generic one of this in the next few years. Next one. Mounjaro, this is the first one that we have in its own class. It is a GLP-1, but also a GIP receptor agonist. Tirzepatide, its generic or it's a regular name. And so it acts exactly like the other GLPs, but it's kind of a stronger diabetes, sugar lowering medicine and stronger weight loss benefit. It has 6 doses. So you start at the 2.5 and then you walk it up every 4 weeks to a max dose of 15. It's also an auto injector like Trulicity. Next. So the DPP-4 inhibitors, like this is Januvia and that class of medicine. So DPP-4 is an enzyme that inactivates incretins, which are GLP and GIP. And so the way Januvia in this class of medicine works is it inactivates the enzyme that inactivates it. So it inactivates this enzyme, so then you get an increase in the incretins, the GLP. So it's basically an indirect way of increasing the GLPs. So where the GLP agonists directly stimulate increases, this one increases it in a roundabout way. And because of the roundabout way, they're not very strong medicines. They only lower your A1C maybe like 0.5% or so. Kind of the similar, like you don't want to give it with pancreatitis, but it's safe. Like they don't cause hypoglycemia, they're weight neutral. So I think of these medicines like if I have maybe an elderly patient that just needs a little bit of A1C lowering, like maybe from 8 to 7.5. This is something that I think of. It's not something that I would start like someone with an A1C of 12 on because it's just like you're throwing water at them. You're not going to do much with that. And then there's a risk of hospitalization for heart failure with 2 of them, saxagliptin and alogliptin, which I've never used, but I think they're out there. Next one. These are it just shows that they're daily pills pretty much. Next. Okay. And then there's no data to say that using the GLP with a DPP4 will give you like extra GLP effect. So it's just a waste of money for the patient if you have them on both. So if you're going to switch from a DPP4 to a GLP, then you just stop the DPP4. And then you do want to adjust these for renal function. If the GFR is low, then Tradjenta is the one that's eliminated through the liver, then that would be the safer one for that. Next. The TZD. So this is just pioglitazone actose. So there was another one called rosiglitazone, which was discontinued. But basically this makes your body more sensitive to insulin, but in a different way than the metformin. Next one. So it is a strong diabetes medicine. It does lower your A1C quite a bit, doesn't cause low sugars. It can preserve some beta cell function, but there are some contraindications. So it can cause like a little bit of weight gain and some fluid retention. So you don't want to cause it, you don't want to use it in people with heart failure or bad CKD or anything like that who are prone to building up fluid. There is a risk of osteoporosis or high risk of fracture. So you don't want to use it in people with bad bones. The data on bladder cancer is inconclusive. So we just don't use it in people with history of bladder cancer or active bladder cancer. And I always just inform them about the kind of inconclusive data. With NASH, this is a helpful medicine, but if you have liver disease from something else, then you don't want to start it if the AST and ALT are over 2.5 upper limit of normal. And then macular edema, but that the eye stuff, sometimes it's just because if you have a strong sugar lowering medicine, sometimes it's that rapid decrease in sugars that can worsen things like diabetic retinopathy or macular edema. Next. That's just the dosing. It's just a daily pill. Next for this one. Sulfonylureas. So with the sulfonylureas, the way that they work is they tell the pancreas to make insulin no matter what your sugars are. So they could be a sugar of 20 and it's still trying to tell your pancreas to make insulin. So we don't like to use them in anyone over like age 60 or 65 because it increases risk of prolonged severe hypoglycemia and falls. And then same with people with CKD because these are filtered through the kidneys, so it'll linger if you have someone on these medicines, and they can have lows that can be really dangerous. Next. So the benefits of these, they are good at lowering the sugars, and it's a preferred treatment in a rare type of diabetes called MODY, and they are cheap, but they're just not that great of medicines, but sometimes that's all we can use if someone refuses injections or has money problems and their insurance doesn't cover anything else. And be careful about hypersensitivity to sulfa. It's not an absolute contraindication anymore for like the intermediate glipizide, and most people tolerate it fine, but it's just something to be aware of. If you're going to use a sulfonylurea, it's recommended you use glipizide because it's short acting rather than glyburide or glimepiride because it can stay in the system longer. And then it does kind of help make you gain weight similar to insulin. Next. This is just the dosing for it. Next. I'll talk about the rarely used stuff a little bit. Next. So meglitinides like Prandin and Starlix, you basically kind of think of these like a short-acting sulfonylurea. So you dose them with meals, and where I use these is like if someone's sugars are pretty well controlled, but maybe they just need a little bit of help like at bedtime, then maybe I'll just give them a small dose of Prandin with dinner to help with that high, and rather than starting them on a short-acting insulin, which is an injection. Next. Amylin analogs, so pramlintide or Simlin, it acts like a short-acting GLP agonist, and it's dosed with meals. It's the only non-insulin that's FDA approved for type 1, but you use it with insulin. So it works the same way as the GLPs, but it's short-acting and similar side effects, like the most common side effect is nausea, that kind of thing. So with this medicine, if someone has type 1 and they're requiring a lot of insulin and they really are trying to lose weight, this is something that you can think about to give them with each meal to help lower the amount of insulin that they're needing. Now, a lot of us just try to get a weekly GLP off label for type 1 to do the exact same thing, because if they're already on 4 times a day insulin and then you add 3 more shots, it's really annoying for the patient to take 7 injections a day. Sometimes if someone's on a pump, then they'll be willing to do it, but it has like a high non-compliance and wanting to stop it. Next. Colesevelam or Welchol, it's a bile acid sequestrant. They kind of don't know how it lowers the sugars, so they think the bile acids may function as signaling molecules in the liver and GI tract for lipid and glucose metabolism. It does have some GI side effects like diarrhea, lowers LDL some. I've never used it for sugars, but it's just something that's out there. Next. And then bromocriptine, the one that is approved for diabetes is called Cycloset, and it's also kind of an unknown mechanism of action, but it's believed to affect the circadian rhythms, and that's mediated in part by dopaminergic activity, and it's thought to play a role in weight gain and insulin resistance. So they think that if you give bromocriptine like in the morning, like a pulse dose type of release, that it kind of resets the hypothalamus circadian rhythm and will help with like those signals that make you want to eat more and contribute to insulin resistance and that kind of stuff. The side effects for this one, GI upset, some dizziness, that kind of thing. Next one. Acarbose. So it is an inhibitor of a enzyme, so pancreatic amylase, and a brush border enzyme called alpha glucosidase. So it results in basically like slowing down how fast carbs are digested. And so it helps with lowering your sugars, and it's cheap and you dose it before meals. But the main problem with this one and why a lot of people don't like it is because they get like a lot of gassiness and stuff like that. Next. This is an algorithm from this is Endocrine. No, this is from, Endocrine Practice. But it's really nice because it tells you like what their A1C is, what you might want to start with. If it's really high, you might want to start with dual therapy rather than monotherapy, and then how to intensify and add insulin, that kind of thing. Next. This is just another algorithm, kind of saying similar stuff, but it includes like other options like SGLT2 or TZD or something like that. Next. I have some mix-up questions. We can do them if you guys want. So a 46-year-old woman is evaluated for type 2 diabetes, diagnosed 3 months ago. She also has hyperlipidemia, hypertension, and obesity. At the time of her diagnosis, her A1C was 8.5 and her BMI was 33. Metformin was initiated. During the past 3 months, she's lost 11 pounds. Medications are metformin, lisinopril, simvastatin. Her vitals are normal. BMI is 32. Her A1C is 8. Which of the following is the most appropriate treatment to start next? Any thoughts?
And everyone's welcome to unmute and chime in or chat in as well.
Okay. So basically, anytime they tell you that someone has type 2 diabetes and they mention obesity or trying to lose weight, they're hinting at the GLP-1 agonist because they can help people lose weight. So the answer here is dulaglutide or Trulicity. Next slide. This one, a 52-year-old man with type 2 diabetes is evaluated after hospitalization for an NSTEMI. He's currently asymptomatic. Medications are metformin, aspirin, ticagrelor, atorvastatin, metoprolol, and lisinopril. On physical exam, vital signs are normal, BMI 28. Physical's okay, and his A1C is 7. Which one's appropriate treatment? So with type 2 diabetes, anytime they tell you type 2 diabetes and any sort of heart disease, they're pointing towards either a GLP-1 agonist or an SGLT2 inhibitor, because those have good cardiovascular data. So of these answers, the only one that's one of those is empagliflozin, which is Jardiance. So it's an SGLT2 inhibitor. Next slide. A 66-year-old man is evaluated for management of type 2, diagnosed 6 years ago. For the past 4 months, he has had fatigue and unsteadiness while walking. Medications are metformin and glipizide, which he's been taking since his diagnosis. On physical exam, vitals are normal, BMI is 28. He has decreased vibratory sense in the great toes and loss of patellar and Achilles reflexes. The remainder of the exam is normal. They give us an A1C of 7.4, a macrocytic anemia, so MCV is high with a low hematocrit, and creatinine is 1.3. So this question is just trying to make you remember that when someone is on metformin for a long time, they can develop vitamin B12 deficiency. And so that's the answer here, that if you have someone on metformin for a long time and they have new or worsening neuropathy, then you want to check a B12 just to make sure it's okay and start them on supplementation if you need to. Next. A 58-year-old woman is evaluated for further management of type 2 diabetes after hospital discharge. She was diagnosed with an MI and subsequent coronary stenting. Her hospital course was complicated by heart failure. A1C was 8.2 while hospitalized. Hyperglycemia was treated with insulin. Her medical history is significant for hypertension, dyslipidemia, obesity, and idiopathic pancreatitis. Medications are metformin, lisinopril, carvedilol, atorvastatin, furosemide, aspirin, and clopidogrel. On physical exam, BMI is 29, her GFR is 52, and sugar is 202. So type 2 diabetes with heart problems. So we know it's either GLP-1 or SGLT2 inhibitor. So then we look to see, there are 2 of them there. So empagliflozin is an SGLT2 inhibitor and liraglutide is a GLP-1, it's Victoza. But they give us something in her question stem where they tell us she had idiopathic pancreatitis, which means that we don't know what caused it. So that would take out liraglutide. So the answer here is Jardiance, A.
Hey, Dr. Barguthi, just real quick. If
Yeah.
that patient did not have pancreatitis, so they're indicated for both SGLT2 and GLP, can you just talk a little bit about how you go, which one to start or when to start one over the other?
So if they were hospitalized and they had a stent and heart failure, then I'm more likely to pick the SGLT2 inhibitor first because the SGLT2s kind of have like that diuretic effect. And they are just approved for heart failure as well. So I will usually start with that. But if it's just like an NSTEMI or STEMI and they had a stent and they didn't have heart failure with it, then I'll choose the GLP-1. I think that might be the last question. Yep, that's it. And here's my email in case you guys have any questions.
Thank you so much, Dr. Barguthi. We so appreciate you sharing your expertise with us. And any questions, comments from the group? Everyone's welcome to chime in. I love that you had those case discussions as well. Very helpful.
All right, thank you.
Thank you. Any of the students have questions or comments? I know this is kind of your first echo, so you're more than welcome to chime in as well, but no pressure. Alrighty, well, thank you again, Dr. Barguthi. If we get any questions through the recording from folks after the fact, I'll send them your way as well. But only announcement I have is the next session will be on August 23rd. Melissa Phillips will be discussing goiter management. Thank you all so much. We'll see you guys next time. Take care.